que no puedo? Okay. Hello. ¿Cuántos años tiene? ¿Y cuántos días de evolución de dolor? Desde que ingresó. So, hello everybody. Bolaños, no tengo el retorno acá. Ah, no, sí lo tengo acá. So, this is a very nice case today. First, I would like to invite you to our live endoscopy course that will be held Friday, Saturday, and Sunday. There are 580 physicians already subscribed. So we have more 20 space for physicians that wants to come. So first I would like to talk about a little bit of our live course. We have also a hands-on course, and we have a very great faculties worldwide that will be stay with us. So just to show you a little and very nice case that comes today. This is 70 years old woman. I'm sorry, with a history of abdominal pain of 1 year of evolution. So this patient have apparent have a pain that probably could be from pancreatic from the pancreatic area, and was admitted at the hospital 1 week ago because big abdominal pain and with a diagnosis of acute pancreatitis. So the situation is that we don't know very well the clinical history of this patient, but this patient have some situations that I need to evaluate very well before to take a decision. So I am working today with a Pentax scope and ultrasound machine Arieta 70. So my concern now, I am at the level of the body of the pancreas, so I can see this area that could be a mass or could be a fluid collection. We really don't know. We need to evaluate very well first. The second situation with this patient is she have the main pancreatic duct dilated. Look. And more than that, it's also irregular. I will follow my main pancreatic duct. I need that you follow this main pancreatic duct here. So you see, it's a little bit tortuous. So if this patient have a lot of clinical data that is not clear for me. First, if is this patient having pancreatic pain during 1 year, that will change totally the diagnosis, because at that moment we can think with this main pancreatic ducts dilated chronic pancreatitis, and with acute crisis now. What do you believe? I am here with my ex-fellows. Come here. This is Clifton one from California, salvadoreño from California. Ah, una repregunta, ¿cuál? There is another question. What is the question? ¿Cómo era la pregunta de qué? No entendí. Ah, no, the situation is here is if this patient have a 1 year history of abdominal pain, we don't know if was pancreatic pain. It's not clear. But if in case that is pancreatic pain, that could answer the question about the irregular main pancreatic duct, and probably it's a chronic pancreatitis that is having an acute crisis. Do you agree? Totally agree. This is a young patient. This is a pediatric patient. It's she's from your group. Yes, that's it. Okay, so at that moment, probably this area, that lesion, i- could be a pseudocyst. Okay, and so we need to evaluate a little bit more. There are some lymph nodes that are inflammatory lymph nodes. These ones, okay. So probably this is an inflammatory lesion. The other situation and the other differential diagnosis that we need to apply, because we are not so sure of the history of this patient, is that this patient could have a mass, and this mass could be a papillary tumor. Okay, but if we evaluate the whole situation of this patient, we need to see very well. So I want to see my gallbladder. My gallbladder, if you see here, is with a lot of sludge. So it's very confused the case. I I don't have a lot of experience, but I don't see any pseudocysts that perform compression of the main pancreatic duct and perform a dilation. So we have a lot of questions. First, is this chronic pancreatitis with an acute crisis? Second, is this a pseudotumoral tumor? Third, this is a chronic pancreatitis secondary to slush. So we have a lot of questions. The only thing that I know is that this patient needs a surgery, needs a gallbladder surgery first. Needs also to be cleaned the biliary tract, because there is a sludge in the biliary tract. Okay, so Dr. Clifton One is one of the professor, the faculty for the live endoscopy course Saturday, huh? My good friend, huh? So we need to evaluate that. So I will try to do first contrast enhancement, just to see the wall of this lesion, to see if this is a mass or not. However, normally the pseudopapillary tumors just perform a hypercaptation of the circumferential area, and there is a hypocaptation inside. ¿Tenemos el contraste listo o no? ¿Dónde está el aplicacionista Itachi? Momento. Sí, vamos a hacer contraste.
Este está como lo hacía antes, doctor. Este sí está, creo que
Ok.
se lo cambió, ¿no? Digo, está cambiado en el otro lado.
El problema es que me cambió ahora la imagen, no sé por qué.
Mire que ya hay.
Sí.
Eso es lo que quiero. Si quieres, yo le dejo
Sí,
el contraste dentro de la otra.
sí.
Dentro de la otra que
Entonces necesito cambiar invertir la imagen.
¿De lado?
No, de arriba abajo.
De arriba abajo. Entonces, izquierda, derecha. Ah, pero este no está así, claro, está diferente.
Okay, wait.
Ahí está.
Okay. Ahora, necesito... Okay. So we have the lesion here in the middle. So in your right panel, you will see the contrast arriving. So, puedes pasarlo. So you can see there is nothing inside. Oh, I think it's a pseudocyst. Ok. ¿Cómo paro el videoclip?
Me empecé con este, pues cámbialo ahí. ¿Sí para o no?
No.
Acá.
Okay. So, one of the big advances of this new machine is that we can do a contrast evaluation. Okay. Fue este, ¿no?
Enter, sí.
So we can do an evaluation of contrast enhancement captation, but in a quantification mode, not just subjective, is more objective. So if you can see there is nothing inside, just the wall. So I believe that this probably is a pseudocyst. The situation is that if this patient continues to have pancreatitis, even if we leave the gallbladder, probably it's a chronic pancreatitis. She have now some morphologic alterations of the main pancreatic duct. So now, ¿este aquí?
No, recuerda que hay que poner el punto para el área de la parte de arriba. Enter. ¿Está?
Oh, okay, that's okay. Oh,
Dos.
okay. So we can evaluate
Muchas áreas, diferentes áreas.
different areas if you want.
Ujú.
So 2 is okay. Okay. Ahora we can see here. You can see here how the captation of the contrast
Time.
was during this time of period of time. and we can see also the hypercaptation area in one moment.
Esta es la que está más más ancha.
So this can give us some ideas. If this patient have an hypercaptation, what is the number now? We don't know exactly what are the numbers of this hypercaptation, but probably could help us in the future to differentiate between some kind of solid tumors. For example, adenocarcinoma versus another kind of lesion. Okay, tissue. What do you think, Jorge? Absolutely. So now we can see also, ¿cómo se llama esto?
In time flow mapping.
The in-time flow mapping. This will help us to differentiate. If you can see here, it's different kind of colors, and it's like a mapping, a color mapping of the contrast.
Depend of the phase the phase of the contrast strip.
No, en español dime.
Cuando dependiendo de la que de la curva donde estemos, ¿no? En el momento, entonces eso igual se puede diferenciar, entonces va cambiando de color dependiendo de cómo vaya.
It will depend of the time and the frame and the.
Podemos analizar de pronto esa que está en el pico.
Yes. So it will depend. This color map will depend from the area, the time of area that we perform a captation. So, for example, here we have more.
Tenemos el color.
Now it's better.
En esta
So we can see here the difference from the colors. You see from the green to the blue, and how do you say this color in English? I don't remember. Violet. So violet is the higher captation, and that's good because we can see that probably there's some inflammatory area. So yes, that's we can graph that. So this is very nice case. Just to show you a little bit the technology and how we can use this technology for the future. So now we will change our scope, and we will perform a fine needle biopsy to see what do we have. Okay, sácalo, ¿sí? ¿Tienes el lineal, por favor? Very nice.
So the analysis is powerful.
Yes.
I never knew we could do that
Yeah.
because it's subjective.
It's objective.
What about the subjective?
Yes, totally agree.
Criticism before Sonova. What? That was a criticism before. No, no, no. That was a criticism.
Everybody's looking to you.
I'm saying that was a criticism before. Now, this new ability will give us objective evidence.
Totally agree. Totally agree. This is a difference, big difference regarding the technology and how we can deal with this. So I think there are some septum inside. It's very
Mixed.
difficult case. I think. I think there are some areas that are confused regarding this case, regarding the evaluation of the pancreas, of the morphology of the pancreas. So it's a very nice case. ¿Me puedes pasar a alinear? Rápido, gracias. ¿Está todo bien? My technicians are not so efficient sometimes. So slowly. Quick, quick, quick. Rápido, rápido, rápido. In United States, they are better, I believe. What do you think?
Slightly better.
Slightly better. No, I think they are better there.
Not like Pentax Training Center.
I don't believe you. You are joking with me. So it's now. Now we will use a needle. I will use a 19 gauge needle, but the standard needle, just to perform an aspiration, to see if this is fluid or not. And regarding that, if this is a fluid collection, we need to perform a drainage. Want this? Guantes, gracias. Gel. Oh. So now we are with a linear scope. We are at the level of the liver. So we see the lesion here. And I will try to pass a needle. So the differential diagnosis is very difficult. Huh? It appears as a solid sometimes. Huh? So necesito una aguja 19, por favor. So I will use a SPECT needle from Boston Scientific, a 19 gauge needle. We can see if there is any vessel here. So this patient, remember, this patient have pain now, and probably because there's an obstruction of the main pancreatic duct, and also probably a pseudocyst with a fluid collection inside. So now I'm inside. I will perform an aspiration now. Por favor. Sí, aspiración. Aspiración. No, grande. No. Oh, it's a fluid collection. This is a pseudocyst. So, what can we do now? I need to aspirate a little bit more to send to evaluation. For the liquid evaluation. No, solo para evaluar nada más. Tenlo ahí en la aguja. Necesito solución salina. So what I will do now, because this is a very small lesion, is 3 centimeters, but she have abdominal pain. So I will pass some water. Okay. Try to increase the size, and I will pass a guide wire to avoid a complication. I will use a hot access now. Más salina. And I will perform a drainage using a hot access. So now we are very well. Okay, give me dame una guía. So I will use a guide wire just to be sure. Normally it's not necessary, but I prefer to avoid a complication now. So this is when the fluid collection is so small, I prefer to pass a guide wire. So you can, the advantage to do the drainage with the hot access now is that you can avoid to use fluoroscopy. Okay, it's okay. Listo, empuja. Empuja, empuja. Niña, tienes que empujar. Ok, ahí nomás. Gracias. Un momento. 10. Sigue, empuja, empuja. Mientras yo retiro. So it's very important that the technician. Espera un segundo. No empujes tanto. Do a step by step. The second tip is to have in your under your vision the guide wire triangle. And I will use a 10 by 10 millimeters hot access. I already see that I already saw that there is not any there are not vessels in the triangle, so we are sure that we can do a good drainage. So this is one of the way to use the hot access. If you see the all cases that we have, in some cases we do not use. So we will have some cases of access drainage Saturday. So I invite you to come to our live congress. 10 por 10. It's fantastic. So this is very important when you are doing the technique to see your guide wire. Moreover, if you are doing that in the biliary tract. The other tip is very important that we can have 3 centimeters at least when you use axios, because you need to open the distal part, and then we need to retard. Retira. Ok, 10. Momento, despacio. I think this will help a lot this patient. Momento, ayúdame aquí, tenme aquí. So now we are very well positioned. My axis is out. I will push a little bit. I am inside, you can see. So I will put my finger here just to be sure. I am sure that I am inside. So I will start to open the distal. You see? Here, all under ultrasound vision. So this is the second step. The third step is just to return a little bit the axis, and then you can release the axis. You see, I release always inside my channel. I am sure now that both parts are in the first one inside the pseudocyst and the second one in the lumen, in the gastric lumen. So this is a very nice case. I think is we finish already. And how many time we need to wait? Just I think in 48 hours, and this will be solved. So probably in 15 days we need to, or less, 10 days, we can retire the hot axis. Huh? Perfect. Perfect. Muy bien. Excelente. Terminamos la transmisión. So thank you so much for your attention. Very nice case today. See you soon. Cortamos.